Today we've been dispatched to Bob. Bob's a 70-year-old male who's been complaining of sudden onset central crushing chest pain. We've arrived and found Bob. Bob's unable to obey our commands. He's got a lower GCS. We're going to do a focused assessment of Bob, ABCs, and a full set of vital signs. Upon doing this, we've found that Bob's got a heart rate of 170, a blood pressure of 70/40, a rest rate of 18, temp 37, and a BGI of 7.6. We've got put a 12 lead on Bob and a 3 lead, and we've found that Bob's in VT. Bob here, he's got significant cardiovascular compromise because of his hypotension, tachycardia, and low level of consciousness. He's been unable to obey our commands. Because of this, I think we're going to call for R50 backup. AE21 calls.
Go ahead, AGT.
Patient in VT requesting R50, thank you.
Copy.
Great. Before we go into our full dive headfirst into our cardioversion, what I think we want to do is just have a quick think about some differential diagnosis. Before we're going to chuck our 12 lead on, taking our 12 lead, just to see if we've got any signs of SVT aberrancy, but it doesn't look like that from history we've taken. No sign of electrolyte imbalance, no history of SVT or Wolff-Parkinson-White. We've got a bit of a background of Bob's medical history. Bob's had a history of cardiac problems in the past. He's had an acute MI 5 years ago and takes citalopram and aspirin. Now that we've decided we're going to dive headfirst and cardiovert Bob, we're going to just go through our cardioversion checklist, which we've got right here, where we attach our defibrillator pads, done right here. Turn our monitor to manual mode. We're going to now select a lead on the monitor with the largest visible R wave. I'm going to pick lead 2 because it's got the largest visible R wave. Then I'm going to select the synchronized mode on the monitor, and that's going to put a little mark above each of the QRS complexes in the patient's VT rhythm. I'm just going to confirm that we've got that synchronization going by just printing a quick strip. Yep, so we've got confirmed that on printout as well. Another thing to make sure we do before we cardiovert is just prepare that in case Bob cardiac arrests, that we have our resuscitation gear all set up. We've got our bag up mask, we've got our suction, we've got our defibrillator, we've got our kit. We've also gained IV access for administration of drugs in the case of cardiac arrest, or for potential chemical or pharmacological cardioversion if we're unsuccessful in our defibrillator. Before cardioversion is a painful and invasive procedure. So what we would do is that if Bob was conscious, if Bob could obey commands, we'd be providing adequate analgesia for Bob. We'd likely use ketamine in this example. Next, we're going to charge our defibrillator to maximum joules. Alright, everybody stand back. I'm going to shock the patient in a moment. Now that I've charged my defibrillator, I'm going to press and hold the shock button to deliver a shock. Shock's been delivered. Now I'm going to reassess the patient. I'm going to go back and do my ABCs again and reassess his rhythm. Unfortunately, Bob hasn't been reverted, but in this case I can re-cardiovert him again. If I was to re-cardiovert, I just have to double check that I have resynced on the monitor, that every cardioversion shock I deliver is synced with his system. is each of his QRS complexes, and just to double check that with a printout each time just to make sure. Today we've been dispatched to a 40-year-old male who's fallen off the roof of a second-story building while water blasting. We've located the patient and found him lying supine. We've done a full secondary survey and a full set of vital signs. The patient's unable to obey commands. He's got a GCS score of 8, of 4, 2 and 2. We've done a secondary survey. We found a 6 cm bulky patch in the back of his skull. His vital signs have come back. He's bradycardic with a heart rate of 50. He's hypertensive with a blood pressure of 160 over 90, and he's got a lower respiratory rate of 12, and his breathing's irregular. That's going to give us signs that suggest Cushing's triad, which indicates an increase in intracranial pressure, which is consistent with the injury we suspect, which is a traumatic brain injury. Because his GCS score is below 10, I'm going to call R50 and call for RSI to help maintain this patient's airway. E21 calls.
Go ahead.
Requesting R50 for RSI.
Okay, ETA 10 minutes. Prepare for RSI.
Beautiful. Now that we've called for R50 for RSI, I'm going to start by going through my RSI preparation checklist. There's a whole manner of things on it, but I'll just go through them detail by detail. Starting off, we just have to reconfirm that the patient's still indicated for RSI. So the patient still has a GCS of below 10 and is at risk of airway compromise. We also have internal CO2 capnography available, so where the patient's not contraindicated for RSI at all. Next, we'll start on the patient. I've attached nasal prongs without oxygen and a reservoir bag, oxygen mask running 10 litres of oxygen per minute. I've also got my manual ventilation bag valve mask with PEEP attached at 5 centimetres of water, just in case we have to manually ventilate the patient. However, this patient's still breathing on their own. We'll just keep this mask on for now. I've attached in my ECG my blood pressure cuff and my SpO2 monitor on the patient, and I'm taking a full second set of vitals. I'm going to then see if I can get in contact, if it's possible, with the OSCE just to update them as to the condition of the patient and give them a bit more information. I've prepared my end-tidal CO2 for the patient when the ICP gets here and proceeds to intubate. I've done a bit of just basic airway care, positioning the head in a sniffing position with a towel under the patient's neck, just to make it easiest for just the patient's general airway management and for when the ICP wants to intubate. I've gained IV access in 2 sites, and I've got a 1 litre of 0.9% sodium chloride running at the moment. I've positioned my monitor so that everyone can see it. I've also got my suction and confirmed that it's working. I've got a full second set of vital signs, and I've generally prepared the area, leaving a space next to the patient's head where the ICP can lay out the intubation roll. I've also just left a space just generally around so that if there's just any junk gets put anywhere, we've got a bit of space. At the moment we're in a residential address, so we've got plenty of space. However, if we were in the ambulance, I'd try to want to minimise all any junk or any kind of bits and bobs that could get in the way. And if we were in an ambulance, we could also start thinking about driving and meeting our R50 on the way. Yeah. And then we've gone through our RSI preparation checklist. It's not uncommon for RSI to fail, and in the case of a failed RSI, we want to follow our failed intubation checklist, or failed intubation drill rather. If the ICP can't visualise the chords of the patient within 15 seconds of laryngoscopy, or has not intubated the patient at all within 30 seconds of the first laryngoscopy, then it's considered a failed intubation. the ICP might then go on to look at some reversible causes about how to manage the failed intubation, and might reposition the airway. They might get you or their assistant to provide some pressure. They might then have one more go, and if that's not successful in the similar criteria as before, or the patient is not getting, the patient's end total CO2 is less than 5 milligrams of mercury after 2 to 4 breaths, then it's considered another failed intubation, and then we have no more attempts at intubating the patient, and we swap back to an alternative airway such as an LMA or an OPA bag valve mask. If the use of an LMA or bag valve mask with an OPA is shown to not have any positive effect on the patient's ventilation, we're getting no chest rise or any, etc., then you might be thinking about potentially going for a cricothoracotomy and setting up an alternative airway in the patient's cricoid. When performing invasive procedures like RSI and cricothoracotomies, it's also always important to think about the ethics and legal parameters around it, and that the patient doesn't have the capacity to consent at this point and provide an informed consent to the patient, to the paramedics and ICPs. So it's always important to always be thinking about that you're acting in the best interest of the patient at all times.